This is my disclosure that there will be some honorarium paid to all three of the speakers. My today's talk is just trying to make the floor ready for discussion on a molecule called injectable semaglutide 2.4. So I'm going to speak on the STEP program and some introduction about importance of obesity to be addressed in this country. So paradigm shift in obesity care with the transformative weight loss evidence from the STEP trial. This is my financial disclosure. So our agenda will have some slides on burden of obesity and need for pharmacotherapy. What are the benefits of semaglutide 2.4 milligram in people with obesity? And do we have enough safety data available to accept this molecule as an anti-obesity drug? So I feel earlier few slides there could be little repetition from other lectures. So obesity is a global health priority, is prevalent, complex, progressive and relapsing chronic disease. So now we start calling obesity as a disease. So there is enough perception on seriousness in the people with diabetes or people with obesity across the globe. That's the main purpose, characterized by abnormal or excessive body fat or adiposity or adiposopathy that impairs the health. And we have around 100 crores or 1 billion people who are affected by obesity. And of them, 764 million adults, 86 million adolescents, and 71 million children. So equally important is young generation like adolescents and children. They also have quite a high amount of obesity. And greatest number of people living with obesity are in the low and middle income group countries, including India. And there is a double burden of malnutrition. So we are facing double burden of malnutrition and obesity both. So this double burden is going to have its impact on the overall health of any of the non-communicable diseases, which includes your obesity, hypertension, diabetes, cancers, and many more. So Indian picture, if you say, we have around 254 millions of those who have generalized obesity and central obesity. Everyone knows that we are more fat in the viscera, and we have more visceral obesity. So around 351 millions have abdominal obesity. And we know that it is once you have generalized obesity or visceral obesity, it is attached with multiple comorbidities, which includes your diabetes, heart diseases, heart failure, osteoarthritis, gout, obstructive sleep apnea, respiratory diseases, multiple things across. So obesity associated with multiple comorbidities. It could be, and there are around 230 odd diseases which could be related to obesity directly or indirectly, and many of them have very strong evidence that obesity is associated with multiple diseases. I can't name all of them, but we will be addressing few of them. That is true. So one is type 2 diabetes, then you have liver disease like MASLD, MASH, cirrhosis of liver, chronic heart failure, stroke, CKD, CA, coronary artery disease, obstructive sleep apnea, osteoarthritis, and of course the gastroesophageal reflux disease. They all are few of the common complications amongst these 230 complications of obesity. And the various mechanisms have been proposed. It could be increased adipokine synthesis at the adipose tissue, lipid toxicity, dyslipidemia, glucose toxicity in diabetes. Then you have the hyperactive sympathetic overdrive, and then you have RAS. Then you have some mechanical factors which could be again causing some of the complications in long term. Now this is very important slide. If you just see the life expectancy, which is decreases with the BMI, and if you see the if you see here, if your BMI is say 22 to 25, so less than 25, the risk of the chances, the almost 80% chances of reaching up to 70 years of age. This is age. This is the 80% chances of you reaching there. But if your BMI is below say around 35 to 40 or 40 to 50, the chances goes down to here 70, next is 50%, 60%, and then up to 50%. So higher is the BMI, say 40 to 50, the chances is 50% chances of reaching to 70 years of age, and when it's 35 to 40, it is 60% chances of reaching to the age of 70. And that is why, that means once your BMI is high, the chances of your reducing your lifespan is more. And this is another very important thing. Once you lose weight, basic requirement to call any glucose obesity lowering therapy efficacy, you have to have minimum 5% or more than 5% weight loss. Any drug or lifestyle modification, if can reduce the weight by more than 5%, we call it as significant. So we always compare the 5%, 10%, 15%, 20% like this. So even if you reduce just 5% of the weight, practically you have the benefit of having increasing liver's insulin sensitivity, reducing hepatic triglycerides, improving beta cell function, muscle sensitivity, abdominal adipose tissues, adipose insulin sensitivity. But when you reduce the weight by around 10 or 11%, then there are multiple other benefits apart from the one which I have told you. There will be gene expression in the adipose tissue, which could be beneficial, and also the inflammatory markers have found to be more beneficial. So reduction in the inflammation when you reduce weight by around 10%. And if you just talk about the liver triglyceride, beta cell function, muscle insulin sensitivity, abdominal adiposity, they are all almost doubled. The benefit is doubled when you reduce from go from 5 to 10%. Moreover, when you go for 15% weight loss, then practically all the benefits are tripled here, as well as you have inflammation benefit, and the liver sensitivity to insulin remains almost similar in all of them, but other benefits are clear. The pleiotropic benefits of the reduction the weight is certainly multiplied, and when you go more than 20%, we say you get the remission or reversal also. And when we talk about the management option, now Dr. Gupta, you have come and your whole team is here with 3 more speakers. They are going to talk on the GLP-1 analog, but tell us, what are the basic management strategies? So we always say lifestyle modification, and lifestyle modification. And we say it can be done only by education, and education. And this particular sentence remains true throughout. But if you talk about the medical nutrition therapy or psychological intervention, it has its own limitation, that you can have the weight reduction from maybe 3 to 5%. But if you go for bariatric surgery, the reduction is maybe around 25 to even 35% weight loss in an obese person. But there is a big gap here in between. And what is that? Between the lifestyle modification and bariatric surgery is nothing but the pharmacotherapy, which will be helping you to reduce the weight by around 5 to 25%. And what that pharmacotherapy or gap is, that we'll try to understand. So let us understand the benefit of semaglutide 2.4. Now I'm just introducing this particular, not going into molecular structure and other things here, directly going to the trial. So we have this semaglutide 2.4 milligram, and this is a once a week GLP-1 analog. And the dose of course start with 0.25, then 0.5, then 1, then 1.7, and then 2.4. So you have a dose escalation like this. And this semaglutide, there are multiple trials called a step trial. So step 1 to 4, 5, 6, and then you have step up to 10, 11. And then you have few of the trial which are on heart failure or preservation fraction in non-diabetics, just obese patient, as well as in type 2 diabetes. And then you have select CV trial, which is CV outcome trial, and essence trial, MASH trial. So wonderful trials which are available. And this particular trial, 1 to 4 trial, you have 68 weeks plus 7 weeks, because half-life of the drug is around 1 week. So they have 7 weeks follow-up again. And then you have the semaglutide, the long-term trial of 104 weeks plus 7 weeks follow-up. And then this is step 5. And then you have step 6 in the Asian population. And there is also China population, which again Asian population is step 7. So you have multiple stepped programs which have been which have shown its effect, not only about the efficacy and safety, but multiple pleiotropic benefits on various conditions, maybe renal impairment, maybe heart failure with rejection infection, cardiovascular outcome trial. You have a trial on MASH, you have trial on osteoarthritis versus liraglutide. So multiple trials they are available. And what is their outcome when it comes to the weight loss? So you have significant weight loss with semaglutide 2.4 milligram compared to lifestyle modification, almost 18.2% up to 18.2%, and the mean weight loss with this drug, and more than 20% weight loss in 1 in 3 patients, and sustained weight loss of up to 4 years has been observed in this, which is a big data. Usually you have a data of 6 months, 1 year, sometimes 2 years, but here you have long-term safety data available of this molecule. And this is the molecule which is showing, this is a graph which is showing the comparison of the weight loss in different step program, and they've shown on average 18.2% weight loss with this drug. Now, this weight loss, if you just talk about the 5% weight loss, so almost 90% of the patient have achieved 5%, 10% almost 70%, 3 out of 4, and then 15% almost 50%, and more than 20 or more than 20% every third person. That means almost 30% of the patient have lost more than 20% weight loss. And this is again 1 in 3 participants have really achieved the weight loss of more than 20%. If you go just beyond the 2.4 to 7.2, then even you can have 21% weight loss. 1 in 3% in this group have more than 25% weight loss, which is as that of the bariatric surgery. Beyond weight loss benefit, you also have the weight circumference, HbA1c, inflammatory markers, lipids, diastolic and systolic blood pressure. All these benefits are again contributing to the benefit in the individual, not only, and which have been contributed not to the weight reduction but to the drug per se. And then you have the SELECT trial or CV outcome trial, which has shown 20% reduction in the MACE in this, and this is the only trial. Semaglutide is the only trial which has been done by GLP-1 analog up till now, and after that the ESC has recommended that should be considered in all patients with overweight or obesity who without diabetes to reduce CV mortality, myocardial and stroke. So MACE outcome has found significantly, and I feel this particular thing will be discussed further. But if you see the separation of these lines started from the very early stage of the initiation of the therapy, and that has been continued. That means benefit you get within 4 to 6 weeks of starting the therapy. The last part is the safety part. So more than 60,000 people across the multiple trials, sustained, pioneer, step clinical programs, and has worldwide cumulative exposure of more than 33 million people years across indications since 2018. And it has shown almost all the safety profile are similar as that of the other GLP-1 analog. And that could be, first is of course discontinuation of the therapy. So in this clinical trial, only 4.3% discontinuation. GI side effects are more common, and that we will be discussing in panel also. Hypoglycemia not too much common here. And then cholelithiasis was found to be in 1.6%. There is no increased risk of CV events, and there is no increased risk of diabetic retinopathy, which is one of the concern in those patients who are obesity without type 2 diabetes, no increased risk of malignant neoplasm, and very few events of pancreatitis. So to summarize, there is a growing burden of overweight and obesity in India, and pharmacotherapy like GLP-1 analog bridges the gap in existing management protocols. Semaglutide offers a comprehensive cardiometabolic benefits, and semaglutide 2.4 offers weight loss of up to 18%, and 1 in 3 achieved more than 20%. The safety profile of semaglutide is consistent with as that of the other GLP-1 analog. With this, I stop here. Thank you very much for your patience listening.